These are 5 cases from the reading room, and they really are just, the sort of stuff that we kind of see every day. But they are a little more complex, and I want to try and help you with an approach of how to deal with difficult cases, how to come forward with a reasonable differential diagnosis. And again, I really don't like that shooting from the hip when I'm showing residents cases. I like them to look at it, tell me what they're seeing first before they come up with a differential diagnosis. If you come straight out, if you shoot from the hip, say, oh, this is an X or a Y without explaining what it is you're seeing on the films, and you're way off, you just look stupid, and it's very hard for your examiner to pull you back to where they want you to get towards the right answer. So the first one we're going to start with is a young man who was transferred from another hospital who presented with a headache and collapse. And these are the non-contrast CT images that came up on our scanner. So we're both no contrast enhancement on these images. And just to start out, basically, if you're given this case, what are the 2 main findings that you see here? And I think it's kind of straightforward in this. There are 2 big findings here. There's hydrocephalus. There's clearly dilatation of the temporal horns of the lateral ventricles and the third ventricle. And the other finding is this very dense appearance to the subarachnoid space. And when you're given this sort of case, that is how you should describe it. There is dense subarachnoid space. You should not come out with there is subarachnoid hemorrhage, because you may be wrong, as you would be in this case. Okay, so you have a case with hydrocephalus and dense subarachnoid space. What are you going to do? What's your differential? Well, the first thing is this could be blood in the subarachnoid space. This could be a subarachnoid hemorrhage in this patient. The second thing is it could be one of those mimics of subarachnoid hemorrhage, what I call pseudo-subarachnoid hemorrhages, and these have to be in your differential diagnosis. So there is, number one is things like cellular material. So patients who have a carcinomatosis. Okay, so there is cellular debris within the subarachnoid space. Infection, so pyogenic infection, TB, fungal infection, or granulomatous disease like sarcoid can all give you an appearance of dense material in the subarachnoid space. If the patient has had a CT myelogram, contrast material looks dense in the subarachnoid space. If the patient has renal failure and meningitis, then that contrast can actually leak out of the meninges and give you contrast in the subarachnoid space, and I'll show you a case of that. Then I have the other 2 entities, which I call pseudo-subarachnoid hemorrhage. Patients who actually don't have anything in the subarachnoid space but look like they have something in the subarachnoid space, and these are very classically misdiagnosed by radiologists. Patients who have CSF hypotension and anoxia look like they have something in the subarachnoid space when they don't. So these are kind of the pseudo-subarachnoid hemorrhages, because there really is nothing there. So in people who have global anoxia and hypoxia, it's thought to be the dense venous stasis, which really looks like they have something there, and I'll show you a case. And the key here is to look at the cerebellum, the white cerebellar sign, and look at the basal ganglia. Patients who have CSF hypotension, again, it's thought to be the venous stasis and crowding of normal blood vessels, but these patients will often have other findings, that's subdural collections and enlarged dural venous sinuses. In these pseudo-subarachnoids, these patients do not have hydrocephalus though, so that should be your key, and I want to show you what I mean. So here's a case of a woman who presents with severe headaches, and you see her, it looks like she's got this kind of density down here. Does she have subarachnoid or even subdural blood? You can see everything looks a little bit tight in this case. If you come up a little high, you can see there are bilateral subdural collections. You can see a fluid level within the subdural collections. And on the post-contrast, you see these very enlarged superior sagittal sinus, straight sinus, internal cerebral veins, and vein of Galen. Even the inferior sagittal sinus, which is often very hard to see on CTAs and on MRAs, MRVs. In fact, it's really well seen here. So there are enlarged venous sinuses. And this is the appearance of CSF hypotension. Patients who have a low CSF pressure, and usually from a spontaneous thoracic leak of CSF, and they present with this sagging brain, and because everything sags down, it kind of looks like there's something going on in the subarachnoid space. But there's nothing there. It really is a pseudo hemorrhage. This is another patient, and this is the classic. This is written up so often in the literature, the non-radiology literature, as where we mess up images. And especially in the forensic literature, patients who die with this entity, and then they're thought to be diffuse subarachnoid hemorrhage. And if you look at this scan, this does look like there is diffuse subarachnoid hemorrhage, right? it kind of really looks like there is blood everywhere in this case. In fact, there is not one drop of blood in the subarachnoid space in this patient. If you look at the cerebellum, it's a little bright. If you look at the basal ganglia, you cannot distinguish any of the elements of the basal ganglia, and this is global anoxia. And this is a classic appearance. It's frequently misdiagnosed as diffuse subarachnoid hemorrhage. Notice there is no hydrocephalus for a patient with diffuse subarachnoid hemorrhage. So global anoxia, loss of basal ganglia, white cerebellar sign, no hydrocephalus. Okay, a pseudo-subarachnoid hemorrhage. So let's go back. We've knocked these off our list because we do have hydrocephalus in this case. Could there be contrast in the subarachnoid space? Well, he hasn't had a recent CT myelogram. He has not got renal failure and therefore have leakage, and I just want to show you what that looks like. Patients who have renal failure and they've had IV contrast, and if they have something like meningitis, some inflammatory process, the contrast can leak, and this patient does not have anything but contrast in the subarachnoid space, but they have vascular enhancement as the key. So let's go back to our list. We're crossing off iodinated contrast. So we're left with either blood in the subarachnoid space in this patient or cellular material, cells from a patient with carcinomatosis, or a patient who has infection, pyogenic, tuberculous or fungal infection, or the patient has sarcoid, and this is granulomatous disease in the subarachnoid space. So we do a post-contrast because we typically do a CTA in any patient we think may have subarachnoid hemorrhage. And this is the CTA appearance. He didn't have any evidence of any aneurysms. And these are the pre- and post-contrast CT scans in this same patient. And there are a couple of things to notice. Again, we can see hydrocephalus in this patient. We can see dense subarachnoid space in this patient. So it's blood or it's our pseudo-subarachnoid hemorrhage. But if you look carefully, you notice on the post-contrast, there's very irregular, ugly meningeal enhancement on the post-contrast image. And another thing to notice about these ventricles, they're clean. There is no blood in the ventricles, which is very, very uncommon for a patient with acute subarachnoid hemorrhage, to have diffuse subarachnoid hemorrhage without anything in the ventricles. So that's why I want to show you. This is our patient, and this is a comparison case. Our patient has dense subarachnoid space. They have hydrocephalus, but they have clean ventricles. There is no density in the ventricles. Compare that to this patient with dense subarachnoid space, hydrocephalus, and the high density layering in the ventricles. This is a subarachnoid hemorrhage from a PCOM aneurysm. Our patient has CSF positive for cocci, and this is fungal infection in the subarachnoid space mimicking a subarachnoid hemorrhage. So when you get a case and it looks like subarachnoid hemorrhage, say there is density in the subarachnoid space, this may be blood or it may be a meningitis. So cocci meningitis, we kind of see a little bit of it around the Northern Bay area. It's also called valley fever. Most patients just have the acute phase. They have a flu-like symptoms when they get the chest infections. Pregnant women and men tend to go more often to the chronic or disseminated forms. So in all these patients, if you're immune compromised, there's a much greater likelihood of going on to the disseminated form, which will give you the cerebral form. But in fact, there's also a 10 to 20 times increased incidence of patients who are Hispanic or African American going on to the disseminated form without being immune compromised. So this is not necessarily a disease of immune compromised patients. And a lot of people write off fungal infection thinking you've got to be immune compromised to have it. You don't. So it tends to give you this kind of cellular pseudo-subarachnoid hemorrhage appearance. And our differential, again, carcinomatosis, infectious, granulomatous disease, clean ventricles, dense subarachnoid space. So just to remember, when you see dense subarachnoid space, don't forget to think of the anoxia picture if there's no hydrocephalus or the CSF hypotension. Don't forget to think about the possibility of iodinated contrast from a myelogram that's been done on the patient, or a patient who has renal failure who's leaking contrast into the subarachnoid space. And then don't forget to think if they have clean ventricles with hydrocephalus, think about our cellular material in the subarachnoid space. And then finally, diffuse density and layering within the ventricles, subarachnoid hemorrhage is most common. Okay, let's move on to case number 2. This is a woman who presents with a 4-week history of visual acuity changes and severe headaches that are worse in the morning. She had a non-contrast CT, she had an MRV. Let's look at more images of her CT. She has altered visual acuity, she has severe headaches, and this is her CT scan. So what are our observations that we're going to say to our examiner? Well, her ventricles are normal size, she does not have hydrocephalus, we don't see evidence of a mass, we don't see evidence of herniation, and there is no radiological contraindication for a lumbar puncture. okay, from these images. So they do a lumbar puncture and they get back an opening pressure of 250, and of course you all remember that normal is around 80 to 150. So she has elevated intracranial pressure. So your job as the radiologist then is to work out why. So it's either primary or secondary. And primary is this idiopathic intracranial hypertension, which we used to call pseudotumor cerebri or benign intracranial hypertension. And this is the phrase that we want to use now, idiopathic intracranial hypertension. The secondary type means there's something causing the hypertension. So there's a mass, there's diffuse cerebral edema, there's a dural sinus thrombosis. So your job is this primary or is this secondary? We go on to do an MR in this patient because we didn't see anything on the CT scan. There's no mass, there's edema. Again, the ventricles look pretty normal. But if you look more carefully, she has an empty cellar. And this is a young woman who should not have a cellar looking like this. And you can see it on the axial and the coronal plane. She got an MRV because you want to make sure she doesn't have a dural sinus thrombosis as the cause of her intracranial hypertension. She's fairly normal looking superficial and deep sinuses, but these kind of funny narrowings of her transverse sinuses that you can see in all three projections I'm showing here, where it actually focally narrows and then returns to a normal caliber. And you can see it here on the MRV and then on the CT post-contrast. They're patent transverse sinuses. They just focally narrow. There's focally stenosis of the dural transverse sinus. And this is a classic imaging feature of idiopathic intracranial hypertension, and I'll show it to you again in a moment. Most commonly in women in the third decade, it is associated, however, with medication. So you can see it in men who are taking steroids to bulk up their muscles can get this idiopathic intracranial hypertension. In obese patients, it's usually with a recent change in weight as well. Classically present with visual symptoms and headaches. So when you're doing your imaging, you're looking for those evidence of a mass, evidence of edema, evidence of dural sinus thrombosis. If you see none of those, then you can raise the possibility this is idiopathic intracranial hypertension. The sort of features on CT that will give you a clue this patient has raised intracranial pressure are the empty cellar, and this kind of tortuous appearance of the optic nerve sheath. And sometimes you can even see papilledema, like you see in this case, where the optic disc is actually inverted in this case. We used to describe pseudotumor as having these slit-like ventricles. It's extremely uncommon to see that. Okay, so don't look for that as your main finding. This compression of the transverse sinuses, they are not focally thrombosed, they are compression, giving this pseudostenosis, is very typical. And it is a compression of the sinuses at their lateral aspect. Remember with dural sinus thrombosis, and Ashley showed a beautiful case, I'm so glad she showed that to show you, it's a filling defect rather than a narrowing of the sinuses. Okay, let's move on to number 3, a woman with a several-day history of headaches, blurry vision, and ataxia. She'd been started on Dilantin a week before because of new seizures, otherwise normotensive. So here's her CT, and here's her T2-weighted axial imaging. So there are a couple of abnormalities on these scans. Let's look at her CT first. So what are the 3 main findings? 1, this is not a great 18-year-old brain. She's got some volume loss, so there's something going on here. She has calcifications of the globus pallidus at the age of 18. This is not normal. And there's very subtle right occipital haziness, which may account for her visual symptoms. So what are we going to do? We could put these together, or we could go on to an MR, which is generally my preferred way to go. And on the MR is really going to confirm that there is abnormality in the medial right occipital lobe, and in fact there is also abnormality in the medial left occipital lobe, which was really too subtle to see in retrospect on the CT, but here it is on the T2 and the FLAIR image. So we're going to do a diffusion then and see if any of this is acute, and sure enough, on our diffusion-weighted images, we have increased signal intensity. It's low on the ADC, so she has an infarct in the right occipital lobe, and she's 18. We go ahead and do an MR while she's on the scanner. Gorgeous vessels. This is a really pretty MRA. Okay, nice duplicated superior cerebellar artery on the left. We don't see any abnormality of the posterior cerebral arteries to explain an occipital infarct. So we have an 18-year-old woman who's been well until a week ago when she developed seizures. On her imaging, she has diffuse volume loss, she has basal ganglia calcifications, and she has an ischemic stroke. So something bad is going on here, and we need to tie this all together. So the first thing I'd start with is the infarct, because this is obviously a pretty bad thing. The other things are probably related. And if you see a young patient, you've really got to have a good list to work through. And these are the things that you should be thinking about and talking about with your clinician for an infarct in a young patient. Under the age of 20, infarcts are extremely uncommon. They're most commonly in the MCA territory. These are the things we need to think about. So under the cardiac things, congenital heart disease, valvular disease, does she have a left atrial myxoma that might be throwing off emboli? Under the prothrombic list, there's a whole list of things, and these are all for the clinician to sort out, but you can say to them, these are the things to think about in your report, the possibility that she has some prothrombic disorder. Then we come to some other things that you can actually be helpful with. Does she have any other manifestations of things like neurofibromatosis, any of the neurocutaneous syndromes, or CADASIL? Does she have evidence of a metabolic abnormality like MELAS or homocystinuria? And then there's the acquired vascular disorders. Dissection, we know she doesn't have dissection. She's a little old for non-accidental trauma. Moya, we know she doesn't have that. We saw the MRA. Any other evidence of angiitis or migraines? And then we see a lot of this is patients who are doing drugs, and particularly methamphetamine, who develop strokes. So the other thing that we noticed on her film is those calcifications. And there's a wide list, but there's really 4 things in a patient under 20 you should be thinking about with basal ganglia calcification. The 4 top things are FARS syndrome, which is a neurological syndrome, typically with dystonia and chorea, not infarcts classically. Abnormalities of parathyroid hormones, MELAS, and HIV infection, congenital HIV infection. This woman comes back 2 years later with a history of malaise and new headaches and hemianopsia. And remember, she had the occipital infarct and occipital hyperintensity. She now has new low density in the left temporal lobe. Here it's confirmed on MR, and she had a diffusion-weighted study done as well, bright on diffusion, low on ADC. This was a true infarct, so she has a new infarct. So whatever she's got is actually progressing, but she's been pretty well for 2 years, so she's got an unusual course. But in fact, this is a very typical course for MELAS. So her malaise was actually MELAS. And it's these acute stroke-like cortical lesions that cross usual vascular territories, classically parietal and occipital. Diffusion is variable. Sometimes they're true strokes, and sometimes they're not restricted on diffusion or reduced on diffusion, and these will normalize later. The classic spectroscopy finding is elevated lactate in the CSF and in normal areas of brain. So what I mean by that is if you put a spectroscopy little voxel over any infarct in any patient, you're going to get this elevated lactate peak at 1.3 in any patient, because that's what infarcts do. And in a MELAS patient, what you want to do is put it over normal white matter, and that's when you get this sort of spectroscopy that you know this is what you're dealing with. So MELAS, as a reminder, I know Arit mentioned this, mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. Classically, in the late teens presenting, although they really can present any age, and I was just at a neuroophthalmology meeting, it was a 62-year-old presenting with MELAS, would never have been top of my differential. But nonetheless, they can present at any age. They tend to have this periodic acute exacerbations, but one of those features is the basal ganglia calcification should be your key in this case. There are a number of theories of why they get strokes. No one really knows. It's possibly this increased brain energy requirement that cannot be fulfilled. Okay, let's move on to number 4. This is a patient who presented with a history of diabetes and hypertension, 5 days of increasing confusion and somnolence. So we have an axial non-contrast CT, and then he went on to get a sagittal T1 weighted MRI. And can you see the abnormality here? What is the main finding here? Now, the CT, I think, is sometimes pretty subtle in these cases, but if you look at the sagittal T1, you kind of have this expanded low-density pons, what I like to call the pregnant pons. This time last year, that's how I felt. These are our axial non-contrast CT. Here is our low-density, kind of expanded pons. It can be very, very subtle on CT, and I would not fault most people for missing this on a CT. Extremely difficult diagnosis to make on CT. But most of these patients usually go to MR anyway because they present with this rapidly declining mental status. They'll have a CT that looks kind of normal and they will go to MR. So here's the FLAIR, T1, and T2 weighted images in this patient that had that kind of expanded low signal intensity pons. Post-contrast, there is no enhancement post-contrast. If we do diffusion, you usually see that there is restricted diffusion, high signal intensity in the pons following the pattern of that T2 abnormality that we see on our T2 weighted images. So our abnormalities here, we have pontine T2 hyperintensity, which is positive on diffusion weighted imaging and shows no abnormal enhancement. What we want to do is look at that hyperintensity. You can see it's very symmetric and it has a bat wing contour. It kind of spares anteriorly those corticospinal tracts and the peripheral tissue of the pons. And this is a fairly classic kind of textbook Aunt Minnie case. We have a differential that we need to consider still. Ischemia, infection, a brainstem glioma, and then white matter pathology, demyelination, myelinolysis, and PML. If we look at our differential diagnosis of pontine hyperintensity and we look at what we find, ischemia is still in our differential. Infection is crossed off without the enhancement. A brainstem glioma is crossed off because of the positive diffusion. Demyelination unlikely with the positive diffusion and without abnormal enhancement. Myelinolysis is still there, and PML is still in our list of differential diagnosis. So let's go back to the history, because I was withholding something from you. This patient had also been treated on admission for low sodium. So this is a central pontine myelinolysis case, that classic bat wing contour, positive on diffusion, no enhancement. Its better term is really osmotic myelinolysis, because it's not always confined to the pons, and in fact some cases do not involve the pons at all. And this is another patient, a woman who's had rapid correction of her sodium following enteritis, and you can see her abnormal signal is actually confined to the caudate and the putamen bilaterally on flare, on T2. Very subtle signal in the pons in this case. And this is osmotic myelinolysis. Bright on diffusion, no abnormal enhancement. Classically, these patients are alcoholics or malnourished patients or patients who've had transplant or burns. Some reason why there's going to be a rapid shift in their electrolytes that is then being corrected. The key with this is that clinically, it's a very difficult diagnosis to make. And I've always wondered why that is, because we go, oh, they've had a rapidly corrected sodium. The reality is many patients have rapidly corrected sodium and do not get this. So the clinicians don't think about this because they correct sodium all day, every day, and this does not happen in many patients. So there's clearly something else going on in some of these patients that leads them to develop the osmotic myelinolysis, because this happens frequently that they correct sodium and nothing goes wrong. Another patient who'd have a liver and kidney transplant, so it's in your back of your processes, this patient could get osmotic myelinolysis. You can see abnormal flare signal, abnormal diffusion signal, and it's true diffusion signal abnormality. You can see it in two planes. It's clearly restricted diffusion in this patient. They'd actually been hypernatremic, and my differential here would still be possibly ischemic. It doesn't have a typical bat swing. It would still be ischemia in this patient. So CPM can be a very difficult clinical diagnosis. You can look like a complete star when you suggest this to your clinician because it's pretty obvious to you imaging-wise. They typically are progressively declining very rapidly, and so these patients typically will get an MR, and you need to be doing MR, especially when your CT is negative in this patient group. You're looking for abnormal diffusion, abnormal T2, and no enhancement in the pons or in the putamina. Okay, let's move on to the very last case. This is a woman who presented with a tonic-clonic seizure following her ERCP. And she did have a known seizure disorder, but nonetheless, we're imaging her because she's not doing well after her seizure. Got a non-contrast CT first, make sure she didn't have a huge hemorrhage. There was no evidence of hemorrhage, and this is her CT. And then she has a coronal flare. We did an MR after this. And you can see this extensive abnormal signal intensity, which appears to be confined to the subcortical white matter. And you can really see it subtly on the CT. It is there, but again, I'm not surprised when people miss this on CT. Here's the rest of her CT. And if you look at this now, you can see this here. This is bilateral, occipital, and parietal, low density involving the subcortical white matter in this patient. This is her MR, and you can see on the flare this extensive bilateral, posterior frontal, parietal, and occipital white matter T2 hyperintensity. We're going to do diffusion because we do diffusion on anybody if they get into a magnet. And you can see there is no restricted diffusion, and here's the ADCs confirming there is no restricted diffusion in this patient. So there's a lot of white matter signal abnormality without diffusion abnormality. So this is an acute encephalopathy clinically and by imaging. So bilateral white matter hypodensity, bilateral predominantly white matter hyperintensity. And the diffusion has told you this is vasogenic edema, this is not a ischemic process or a demyelinating process. And this is a classic appearance of PRESS, posterior reversible encephalopathy syndrome. There are a number of other names, but again, they're trying to keep everything down to one name now, and this is the preferred terminology for this disorder. There are a number of theories of why patients get that. The most current theory, and this, if anybody's interested, there's a fabulous 2-part series of articles in the March and April 2008 AJNR about the pathogenesis and the imaging findings by Bartinsky, a guy from Pittsburgh, that is really a beautiful, very straightforward, very easy to read discussion of PRES. So you really feel at the end of that you'll really understand this. But the theory it is vasoconstriction, and patients are actually hypoperfused, although not truly ischemic, but they get leakiness and vasogenic edema. But they can go on to areas of ischemia, and that's why we image as well to look for areas of ischemia. Every time you see an article about this entity, there is a new cause listed, and there are so many associated conditions with PRES that it should be something in your differential all the time. There are many different drugs that can cause this. Hypertension is a classic one. Pregnant patients with eclampsia or preeclampsia, a huge list of different things, and there are new things added to that list every time something's published. A young patient with prior bone marrow transplant, altered mental status, again, parietal asymmetric in this case, and occipital areas of marked, predominantly subcortical white matter. It can involve the grey matter. You can see there's no restriction of diffusion, there's no real enhancement, just a lot of swelling, and this is another case of PRES, reversible. A man with new onset blurred vision and a history of severe hypertension, again, predominantly subcortical white matter signal abnormality bioccipital in this case. But on this patient's diffusion-weighted images, we do have an area of high signal abnormality. Notice that it is nowhere as big as the whole area here of T2 abnormality. This is restricted diffusion, and this is one of the complications. And about 10% of patients will go on to have either hemorrhage or infarcts in association with their PRES. But this is the non-reversible bit, so this is the value of diffusion here to tell you most of this process is vasogenic edema. There is a small infarct in this patient. So clinically, PRES is very difficult. Again, you can look like a star if you throw this out and say, could this be PRES? This is vasogenic edema. The diffusion imaging is important for predicting what is not reversible. So we've had 5 cases that I've discussed this morning: pseudo-subarachnoid hemorrhage, idiopathic intracranial hypertension, MELAS, and that idea of how to deal with a young patient who has strokes, osmotic myelolysis, and PRES. What I kind of want to emphasize again when you've got these complex cases, describe the findings before you jump to a diagnosis. State the likely differential, and then if you're not getting anywhere, they're like, what would you do now? Suggest where you'd go next. Would you add diffusion? Would you add an MRA or an MRV? Would you suggest spectroscopy that might help you make the diagnosis in this case? If you're left with a list of cases, if you've got 3 or 4 differentials, always list the one with the poorest prognosis first, the one that needs to be excluded. And what I mean by that is you need to make sure that if there's anything that's potentially treatable and reversible that needs to be fixed now, that should always be the first thing on your list.